especially on such a nice day. So it was really great to drive out of the office and not be in four walls and get to have this sunshine, because it really was great. And I walked up, I wasn't quite sure where the front door was, and when I walked up, you know, the residents are outside and breathing fresh air, and it really was, it was nice. So I'm Steve Grekin. Bedside Dermatology is a company that I started about 17 months ago. I truly started it 17 years ago when I was fresh out of my dermatology residency, when a family member asked me, would I come to see their mom in the nursing home? And I said, sure. I mean, you know, I was young, I wasn't married, I didn't have any kids, I didn't have anything else to do. So I said, sure, and on my way home I went, and I thought, oh my goodness, what an amazing need. And just walking in the, I guess that was the side door, I don't know, it was the front door, whatever door I came in, you know, there are three people sitting in the hallway, and I said to Shannon, oh my goodness, did you see that guy's arm? I mean, there's a guy sitting with a lady in a wheelchair. I mean, the guy must have 10 skin cancers right on his arm. So what I found, and the reason that I started doing this was, my grandfather was in a nursing home. He was a very successful guy, had great insurance, went to any, you know, the best doctor there ever was for whatever was wrong with him, and then he had Parkinson's disease. It was sort of end stage, was basically killing my grandmother taking care of him, as I'm sure you know that story. So he went to live in a facility, and it was amazing. You couldn't get a doctor to come and see him. And so that was sort of the impetus of how we started Bedside. So, and it was several, like I said, 17 years ago. And then, oh, life happens, you get married, you have kids, you get busy, you have this booming practice where people come to see you and you forget about the people that can't come or the cost involved. So our mission at Bedside is to maximize the well-being of our patients and the health of their skin. We provide proven treatments at our patients' bedside in a comfortable environment while utilizing all the same things that we do in the office. Next slide, please. So sort of a spiritual thought that we started with years ago was that we asked for strength and we were given difficulties to make us stronger. And it really applied to the nursing home facility. So what happens? You know, somebody's got something. Everybody here tries to do the best that they can. You ask the doctor that's here, the family doctor, the geriatrician, whatever, to come and try to help. And sometimes they can't help. And so when you read through this, it basically tells us, you know, that you have to go above and beyond. You have to try to help the staff. Next slide, please. Help the people. These are sort of an overview of the conditions that we see in elderly people. The first one, this actinic keratosis. These are pre-cancers that turn into squamous cell cancers, kind of like the gentleman that I mentioned to you that I saw at the front desk or front hallway walking in. He has those. Astiotosis, dry skin. When we live in a communal environment, typically, elderly people are cold, so the heat is on higher usually. So we dry out and dehydrate the people's skin. Then also the soaps that we use in an institution tend to be a bit stronger, and so they also remove moisture from the skin. So that's a second disease. Basal cells are skin cancers, so are melanomas. Notalgia paresthetica is very common in the nursing home population. It's itching. And it's typically itching between the shoulder blades. And you'll see the people move in their chairs, they move against their bed, they try to scratch. They really have a difficult time. So that's another one. Itching in general, just the regular pruritus, that's total body pruritus. And we see a lot of elderly people as renal function decreases, the kidney output decreases in elderly people, we find that it causes them to itch. So that's another one. Seborrheic dermatitis, that's a fancy name for dandruff, but it's not just dandruff of the scalp, it's dandruff of the face, the chest, the back, things of this nature. When we get older, we don't metabolize oil the way younger people do, so therefore it sort of lays on our skin, burns us, and causes these kinds of conditions. Next slide, please. So when we get old, we get rough, dry, loose facial skin, especially around the cheeks, the eyes, the jowl. We get thin skin and we bruise easily. How many of you have seen patients that, and you look at their arms and the family members come in and they say, what are you doing to my mom? Why is her skin like this? Well, we all know we're not doing anything to her mom. It's that the skin gets thin, and as it's thin, the capillaries are right on the surface, and when the capillaries are on the surface, they bruise very easily. There are some things that we can do to toughen the skin. Next slide, please. So what do we do to contribute? Well, I put this slide in for all of us because it's everything that we do. We don't drink enough water, we don't eat properly, we smoke, we drink alcohol, we're stressed, gravity, obesity, lots of sunshine. That's what led all of their problems, and I tell you this so that we can prevent them in ourselves. Sun damage, it comes from UV rays. It's what we know. It's why you should never let you or your kids go to tanning beds. All you're doing is giving yourself ultraviolet. Next slide, please. So actinic keratosis, these precancerous lesions that you see on sun-damaged skin. This is the most common skin finding in the elderly. We see it frequently, every single day. If left untreated, they develop into an invasive squamous cell carcinoma. This is really the reason that I'm here. So all of these sores that don't heal on our residents within 2 weeks have a potential. In the slide it says 20%. It's fine. But actually, in clinical practice, it's greater. Next slide, please. So it's the scaly spot that never goes away. And if you see it, wow, it's hard to see there, sorry. But you can see, we're such a small group, we could actually just show everybody. If you can see right here, it's this scaly spot that doesn't go away. You've all seen it. We could walk through the halls, and of the 40 or 50 residents that are here, easily 30 of them have these lesions. It's that prevalent. Next slide, please. So one more. How do you do this? We treat it with liquid nitrogen, or we treat it with a topical therapy. Every treatment that we perform on residents, nursing homes, assisted living, senior apartments, we have tailored them so that it's less work for you, not more work for you. The last thing any of you need is more to do. So when we come up with our therapies, we treat it so that it's less for you to do, and that we move on and they're treated efficiently. Liquid nitrogen is our easiest thing. Astiotosis, we talked about, it's this dry, cracked, scaly skin. We see this on the lower legs. We see it anywhere in the nursing home population. Next slide, please. See it on the legs like that. It's called eczema crackle. It just looks like if you touch them, the skin's going to crack and break. Next slide, please. Dry, itchy skin, same thing. This is on the back. Again. So how do we do it? We try to eliminate aggregating factors. In many of the facilities where we've partnered with the management, we go in and evaluate what kind of soaps they're using on shower day. We try to tell education for the staff as far as how to hydrate and moisturize the skin on shower day. It's a simple thing as applying moisturizer to wet skin and then patting the patient dry. It seals in the moisture, it corrects this problem. When it gets bad, we use topical corticosteroids, and we also like to use super fatted soaps. So out in the public, when you go to Bath and Body Works and you use all those smell good body gels, they're really not doing a good job. They're actually sucking out the moisture from your skin and making it worse. Next slide, please. So basal cell carcinoma, if you see that, sorry.
What's super fatty soap?
Super fatted soaps are soaps like Dove soap, oil of Olay, Tone, Caress, things like that. In the institutionalized patients where you use a big jar with a pump, they specifically say super fatted soaps, and they're hydrating soaps. So they help seal in moisture without taking it all out. Basal cell carcinoma, these are these pearly little things that you can see right here. These are sores that don't heal. They look like a little pearl stuck on, and you see little blood vessels. These typically do not go in the body, so they're not as worrisome to us as squamous cell carcinomas. However, they're locally destructive, and they're fairly fast growing as far as skin cancers are concerned. So if this is on somebody's face, their nose, it starts eating it away. It does become a problem for you because wound care becomes a big issue. And so that tends to be a problem as well. Next slide, please. So there's another picture where it's got a little crust on it. Next slide, please. And yet again, another one. It's sort of that pimple that never heals. Next slide. So how do we do that? Again, we're able to treat these at the bedside. Simple excision, electrodesiccation, and curettage. When our team comes in, we have a complete bag. It has everything that we need, from gloves to bandages, local anesthetic, all of the instruments, everything's sterile, and it works quite well. Next slide, please. So malignant melanoma, these are deadly melanomas. 1 in 5 patients develop a metastatic disease that results in death when you see a melanoma. These are pigmented, they're brown, black, purple, gray, blue lesions. Typically, they don't bleed. If they get to the point where they bleed and we haven't diagnosed it, we've really not done our job in an efficient manner. Next slide, please. So things that we look for are the A, B, C, D, E's. I like things that are easy to remember. So asymmetry, that means you can't fold it on itself. It's irregular. Border irregularity looks like a little mouse has been nibbling on it. And if you look right here, see how it sort of juts in, juts in. It's not smooth. It's not homogeneous. It's not round. It's not nice edged. So color variegation, things means any differentiation in color. Diameter bigger than a pencil eraser, that's 5 millimeters. So if you have a little pencil eraser and you touch it to something, you would think about that. And evolving, if somebody says to you, you know, I didn't have this mark on my hand, you know, and you watch it, you would call us and we would take a look at it. We use something called dermoscopy. It's a handheld microscope. It lets us look through the skin and evaluate the cells. It's state of the art. Each one of them is about $1,400. Very, very few dermatologists use it in their office, let alone when they come to see the patient. It helps a lot. Early detection leads to cure. That's good. Melanoma risk factors. These are the things. I tell everybody: blonde hair, blue-eyed, fair-skinned individuals with lots of sun exposure. Next slide, please. So how do we do it? Early detection is key. This is the reason that we do full-body screening on all of the residents. We typically do it when we enter a facility. We start in a stepwise fashion. We see everybody. When you get new admissions, they're on our list in our little referral books, and we treat them. We look for this. The number one lawsuit against nursing homes and nursing home physicians other than slip and fall. So what we're talking about is a failure to diagnose. The diagnosis is actually melanoma. And the reason being is that it's not the person that sues the facility or sues the primary care doctor, it's the family. Because, you know, they figure, oh, we're going to hit the lottery, and look what killed grandma. She was doing great in the facility. Next slide, please. So that's what we do. Notalgia, I told you about this. It's that itching, and it's right between the shoulder blades. See that sort of darkened area? It's a disease that occurs more commonly in the elderly. So it's something that we see in the nursing home. Very difficult to diagnose, you know, especially in patients that really can't complain a whole lot. But if you see them moving around and rubbing on things, you know they have this, and there are some treatments for this. Next slide, please. So next slide, this unrelenting black. Yep. And how do we treat it? We use some topical creams. They're applied once daily, typically, and that takes care of it. Sometimes we give a pill that's at the bottom, gabapentin. Next slide, please. That's for difficult cases. I like this slide. You know, in the jungle you see animals and they'll rub up against anything, and you see as we get older and we're not able to reach certain areas or tell people what's wrong, you notice that the behavior is the same thing, and that you see this kind of movement. This is itching. Itching is actually, God bless you, itching is actually worse than pain. They've proven this scientifically, that itching can literally make somebody crazy. So if our residents are itching, we try to control it, again, with very simple means, the soaps, the topicals, and also some antihistamines. The biggest issue at the bottom here is this diminished barrier repair. We don't even know what that means, but in the old days anybody had kids that have eczema, if you brought your kids to the dermatologist that had eczema, they would tell you, don't give your baby a bath. You're giving them too many baths. And then they tell you, just bathe that baby once a week, once every 2 weeks. That's absolutely the wrong thing. That's what we see. You know, how many people in the room took a shower today, right? We all shower far more than even the residents are able to be showered. So the barrier function is asked to hold more moisture, but it can't do it when we're aging and things change. So what we do is we help repair that barrier with the same things that I told you, the soaps, how we shower, how we apply moisturizer while we're wet, and then pat dry. Next slide, please. So those are all the things that I just told you about, how we fix it. Next slide. Seborrheic dermatitis. This is dandruff is what we see in all of us, dry, flaky, itchy scalp. However, in the elderly, it moves, so it gets on their face. I don't know if you have any older gentlemen that have bushy eyebrows, and you look and they're all sort of scaly around the bushy eyebrows, down around the nose, down in the corners where the nose meets the cheeks, and around the mouth. That's seborrheic dermatitis. That's also dandruff. How do we treat it? We treat it with some creams and also a shampoo. So when you're shampooing, we might write a different shampoo for you to use, and then you can wash the face with that shampoo. It takes it away. Why is this important? Because you can develop in an older age an allergy to this Malassezia furfur. See where it says etiology from abnormal sebaceous glands? That Malassezia furfur is a plant growing on them. We can develop an allergy to this, and what that does is cause a severe allergic reaction. The skin cracks and breaks open and bleeds. Infection gets in, boom, the resident has to go to the hospital for a cellulitis. Let's face it, what we do at bedside, what you do here, we get a paycheck by keeping the patients here. And that tends to be our goal, is to keep them here, keep them happy, keep them out of the hospital. You all know what happens when your patients go to the hospital. They come back, are they ever better? No, they're always sicker. We all know that. So that's a very important thing. Seborrheic dermatitis, something as simple as dandruff, you know, what does it do? Next slide. So the scalp itches, next slide, their hair's falling out, all those kind of things, next slide. These are these little waxy, warty growths. Anybody ever see these things on our residents here? I sort of see some heads bobbing. Everybody sort of sees these things. These are very common in the elderly. If they're not in an area where they get bumped or rubbed or bothered, there's nothing wrong with them. If they're around the bra strap, the waistband, under the arms, on the face where the glasses go, this becomes a big problem, and we have to treat them so that, again, we don't get a comorbidity. We treat them with liquid nitrogen. It's very simple. We do it right at the bedside. The patients are so happy. They tell us, oh, I had this for years. I never knew it was this simple to get rid of it, and it prevents a problem. Next slide, please. We can go again. Squamous cell carcinomas. I went through this when I taught you about the actinics. These potentially go into the body and can be deadly. So these are the ones, remember those precancerous ones that turn into something 20% of the time? Well, that's what it turns into. They're a little bit slow growing. If they're tender, if they ulcerate, or if they bleed, you want to call us right away. If we haven't seen it, or if it's not in our note from our initial assessment, you would want to call us and someone will be here and take care of it. Next slide, please. Next slide. And one more. We do it right at the bedside. It's the same slide as the basal cell carcinomas. Next slide. Warts. People get warts. We don't see this as much in the elderly as we do in the general population. It seems that their immune system doesn't recognize that the wart is there. Actually, in the elderly, we have two things. We either have a decrease in immunology or an increase in the functioning of the immune system. And everybody's a little bit different. It all depends. If you see these warts, we'll come in, we'll treat them. Next slide. And again. So review of the skin conditions. These are the things that we see commonly. They're on your sheet in addition to some other ones, hives, things like that, that we'll go over, and fungus. So in the fungus, we see a lot of fungus in the nursing home population. It has nothing to do with the nursing home. It has to do with the age of the patients. So the population that you see typically tends to be a bit older. It's a second from the bottom, I think on the front page there. The tinea, it's ringworm is the generic term for it. Yeah, and it's a problem of moist areas. We see in the nursing home population with the women under the breasts. As we age, the breasts tend to get larger. They're not suspended quite as well. They sag. It's skin on skin. Moisture is there, and we breed these yeast and fungi. So that's another one. Let's carry on. infestations. So somebody asked, are we seeing a lot of this? We touched on it before some of you came in, bed bugs. A doctor at one of our homes downriver mentioned to me that he's convinced that the hospitals are sweeping this issue under the rug. They're not recognizing that they have a bed bug or infestation problem, and so they're sending you, the residents, back bitten by these bed bugs. The bed bugs can be in their luggage, in their belongings, on their person or their clothes, and they spread amongst your residents. So infestations are real. Why do we see them in this environment more? Well, if you read on the third one, transmission occurs via direct close contact. We live here in much more of a close contact with many more people than we live in our own homes, so this is why we see it. Next slide, please. Scabies, head lice, and bed bugs. We see them. It's sort of funny. A lot of homes who their corporate offices either don't know about us or didn't feel that it was important or whatever, just sort of forgot about us. The minute they get an outbreak of scabies, they are calling 911. When can you send somebody here? We've got scabies, we think. I will tell you, 80% of the time it's not scabies, all right? 80% of the time it's astiotosis. It's been misdiagnosed, and it's just let to go on and on and on without proper treatment, and then we have a worse problem. So what we typically do is we do an in-service, just like we're doing today, to talk to you about infestations to give you a better idea. Next slide. So introduction. Scabies has plagued mankind for over 2,500 years. It's a worldwide problem. It's seen in all socioeconomic and racial groups. The spread of disease is hastened via lack of public awareness, overcrowding, and delayed treatment. So the story that I just gave you about the homes that call us and say 911, listen, you can call us. If you see scabies, you think it's scabies, you call us 911. The last thing we want is to have to see all 40, 50 people living here and have to treat them. It's a nightmare for you. It's a nightmare for us. If we can find it, isolate them, treat them effectively and efficiently, we stop the problem. That's what it looks like. My kids think it looks like a Star Wars creature, but my kids are little, so it's a creature that you and I never want to see. Next slide. So it's an 8-legged mite. You can see that picture up in the corner. The entire life of the mite is lived within the epidermis, the top layer of the skin. It can live for up to a week off of the human host. First-time infestations take 2 to 6 weeks before the host's immune system becomes sensitized. This is an immune phenomenon. That's what makes the rash. Next slide. Clinically, where do we see these interdigital spaces in between the fingers, the toes, the wrist, the back of the ears, the waist, the ankles, the penis, the scrotum, the vulva in women? We see them in linear burrows, and we see areas of crusting and little vesicles that form pustules. Very important. Next slide. This is what it looks like. See the little pustules? This is on a hand. See these right here? That's what it is. This looks almost like dyshydrotic eczema. A lot of the people that aren't trained will say, oh, that's an eczema. That's not scabies. Well, we have to check. We have to make sure. Next slide. Here's again, this is obviously in an infant where it's really scaly, but see on the back of the wrist, see that scaliness, and see how it's sort of cracking and opening. You could see why this could be mistaken for an eczema, but it's not. It's scabies. Next slide. So the treatment, we treat with topical treatment or we use an oral pill. Let's be honest. As I said at the beginning, we're a team. We're here to help you. We rely on you to help us. I'm not going to make your jobs any more difficult. If there are no contraindications, we give them ivermectin pills. 2 is basically the dose for an average adult, and we give 2 pills once. Let's say we did it today. It's Monday. We give 2 pills this Monday, 2 pills next Monday. They're finished. After the first dose of 2 pills, 48 hours, they can be put back in with their roommate. Now, if we have a recalcitrant problem, then we have to go to the topical as well as the oral. Next slide. So the ivermectin, we said difficult cases. The reason we say difficult cases are, these are difficult cases because of the need for isolation, and it causes undue burden on all of you. So institutional setting isolation is important to prevent the control of disease. Next slide. Head lice, they're blood-sucking wingless insects. 12 million cases in the US worldwide. Again, all ages, sex, races, and classes. They're passed head-to-head contact or through these fomites. These fomites can literally jump. Now, when I do that, Shannon will start itching for the rest of the day, because you say about this and you think about it and it makes you itch. That's what the louse is. That's what it looks like. Again, my daughter, when I was reviewing this, she goes, "Daddy, it looks like a Star Wars creature." Next slide, please. So it's highly specific to a human host. They don't live on dogs. They don't live in furniture. It can live for 1 month. It can lay 10 eggs a day. They typically do not live off of the host. Next slide. They're found on the scalp, behind the ears, and the nape of the neck. You have to look for this, and you have to see, and then you have to look in patients to see if it's easily contracted. So if somebody laid down on the wrong pillow, somebody sat in a different wheelchair, somebody laid on a physical therapy pad or something that was the same, they could conceivably get transmitted. Next slide, please. So that's what it looks like with the nits attached to the hair shaft. Do you see these little scaly, sort of crusty things? That's from the patient's scratching and picking. They get a prurigo nodularis or an excoriation from this, and that's a problem. Next slide, please. There they are, those buggers stuck right on there. We thought we had a case of it. My daughter's 8 that I keep talking about, and she went to some kind of gymnastics birthday party and swore that this thing jumped on her pony holder. My wife bagged up every pillow, every stuffed animal, oh, it was crazy. Anyway, next slide, please. So moms, all the moms are laughing because you all know about this. In the school, you get these notes, and it's really something. 2 applications of a treatment 1 week apart. Permethrin, see down at the bottom again, our ivermectin. Look, that's what we do because it's easy, it's cheap, and it's not labor intensive. And I know I sound like a broken record, but you know what? We try hard to make it simple. Next slide. Bed bugs, blood-sucking parasites of mammals and birds, and they hide in the cracks and crevices, behind peeling paint, in the beds, things like that. Next slide, please. That's what they look like. It's a bit of a problem. Next slide. We treat it the same way with the permethrin and things like that. Next slide. So they can be a vector of other diseases as well. Next slide. That's what it can look like. It's a problem. Next slide. There it is. And they're just miserable. Next slide. So we use it. We have to eliminate the cracks and crevices in the paint and things like that. Use insect repellent. I'm sure the state's been in. I'm sure you've been told about how to treat this. It's more of an issue. I treat the skin. How you treat the facility is out of my area of expertise, but we can always offer some help. Next slide. So infestations occur in settings of close contact. Despite our best efforts, they're treatable if we arm ourselves with education and timely intervention. If you suspect an infestation, please call us immediately so we can tell you about it. Next slide. So our family's growing. We're now in over 47 facilities in Michigan. We're happy to bring our derm services to you, and we thank you for joining our family. And I'll answer any questions you might have. I guess I covered it all, huh? Have you seen patients walking around that you've seen some of these things that I showed you today? Have you noticed any of the sort of those like we said, those actinic keratosis, the brown waxy things? Everybody's nodding their head. Yeah, it's pretty universal, and we see them in all the facilities that we go to.
We'll be getting with Mohammed to initiate our first day here. That hasn't been identified yet, but hopefully be relatively soon. So any patients that you see, we're going to be placing some referral books at the nurses station, and you can just actually write the names right in these books. And we'll also be placing, this is what they look like, it's easy referrals for bedside dermatology. And then we'll be placing more of these nurses' skin health awareness sheets at the nurses' station as well. Did you find it helpful? Yeah.
Oh, good.
Good. We have a gift for you too for coming in today. So thank you. Dr. Grekin.
This is one of those great lotions, like we said. If you apply this to wet skin, you can put it on your face, you can use it on your body. I invented it years ago. It has the highest concentration of vitamin E. Vitamin E is very potent humectant. It means it binds water. So if you put it on with a little water, I think you'll find that you'll really like it. So, and I thank you for your attention. Thanks for having me. Thanks.
What insurance do you accept every insurance?
Yes, yes. Most everybody in the nursing home population has Medicare, which is primarily what we have, what we see. Is it different? Do you have anything different?
What do you have? Oh, she's asking.
Oh, for you. Oh, you can come and see us anytime. Well, we have a special, we do some things where we have, where we also do Botox and things like that, fillers and treatments like that, and we give all of our staff a 20% discount. So whatever home you are, you just tell them when you call the girls, make an appointment. If you call the bedside number, Shannon can tell you where is the most easily located place based on where you live, and just tell them where you work. It's nice. Do hair removal. We do all kinds of things. So it's fun. Yeah, we see kids. Yep. Yeah, I say from...
Location on 12 Mile Warren?
Yeah, that's where the corporate office for bedside is. We have Warren, Wyandotte, and Southfield offices. Good. Well, thank you.
Thank you. We look forward.
Hi there. I'm Dr. Stephen Grekin. I'm the CEO and founder of Bedside Dermatology. I wish I could be here in person with you today. However, I decided this was the next best thing. I wanted you to hear straight from the horse's mouth why we created Bedside Dermatology and how we think we can help you. The why occurred 17 years ago. I was asked to go and visit a patient in a nursing home. The family member, the daughter, was actually my patient in the office, and she said her mother was getting worse and worse. It was very difficult to get the ambulance, bundle her mother up. We live in Michigan. It was cold. It was winter, and get her to the office. It was almost impossible, and she felt that she wasn't doing her mother justice by taking the care that she needed when dealing with a skin condition. Of course, I went on my way home from work, and what I saw was a tremendous need. To get specialists into the nursing facility is a very difficult task. As I've already explained, it's hard to get the patients to come and see us. Bedside Dermatology is uniquely created to provide the state-of-the-art care for the skin, hair, and nails that every one of your patients needs. In addition, we're able to diagnose, treat, and most often cure right at the patient's bedside. So what could be better? The comfort of their own bed. When you're having a scary procedure, it's no longer scary because you feel warm, safe, and protected when you're in your own environment. So the presentation is going to go on without me today. I look forward to meeting you in person in the very near future. And more importantly, we look forward to caring for your patient's skin. I'm Dr. Stephen Grekin, the founder and CEO of Bedside Dermatology. Bedside Dermatology was my brainchild 17 years ago when I was asked to basically make a house call. I found that there was a tremendous need for the services that we could provide at the bedside. What we found by being in over 47 facilities to date is the staff says, hey, what about me? So what we've done in response to that is we offer a free skin screening to all of the staff. Of course, we have to make an appointment, we have to have a designated room, and we have to have a permission slip, but we're happy to provide this service free of charge to all of your staff members who have concerns about their skin. It was very interesting when they spotted that we were taking better care of the residents than they were taking care of themselves. So it's really quite nice to be able to offer this service to all of the facilities who participate in our Bedside Dermatology family. As always, here's to looking good in your skin. I'm Dr. Stephen Grekin, the CEO of Bedside Dermatology. Many of you might be thinking, why are you listening to this? What do we need Bedside Dermatology for? Well, number one, when the state comes in and looks at your resident's skin and cites you for problems, it's very expensive. Most of these citings can be avoided by taking simple steps to help our residents keep healthy, fresher, younger looking skin. It's not all about the appearance, it's all about the function of the skin. If we repair the barrier, the skin doesn't break down, etc., etc., etc. Do you need us, and are we going to cause you more work? My categorical answer is you absolutely need us, and you absolutely not. Well, let's try that one again. Stephen Grekin. I'm the founder and CEO of Bedside Dermatology. Many of you are saying, oh, that sounds great, bedside dermatology. What do I need you for? Well, you need us to keep the state, the big bad wolf, off your back. So many of the things that get cited in nursing home inspections by the state could be avoided with proper skin treatments. What I mean by that is not just having wound care and skin care training nurses, but actually diagnosing, treating, and curing skin diseases. That can keep the big bad wolf from knocking on our door. So, is it going to be labor intensive on your part? Absolutely not. Is it going to be beneficial for your patients? Most definitely. As I said, I'm Dr. Stephen Grekin. I'm the founder and CEO of Bedside Dermatology. We're here to help you deliver your residents the best skin they can possibly have. Many times the staff sits here and listens and they say, wow, that sounds great, but what's in it for me? Well, what's in it for you is in-service education. We pride ourselves on being cutting-edge, state-of-the-art dermatologic facilities. However, we teach you how to have a lot of that knowledge. We have specific handouts that we create and leave behind. We have literature for the families, for the staff, for the administrators, for the directors of nursing. I lecture worldwide on skin diseases. I'm considered an expert in many of them. We look forward to sharing our expertise with you on a monthly basis.